Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. A neurological disorder is a complication that occurs in the brain, spine, or nervous system. There are more than 600 kinds of neurologic conditions, and accurately diagnosing them requires a combination of an experienced neurologist's expertise and state-of-the-art diagnostic equipment. On today's show, we will learn more about Parkinson's disease and a new treatment option available for patients. We are pleased to welcome Dr. Robert Gross, Joint Chair of the Department of Neurosurgery at Rutgers Robert Wood Johnson Medical School and Rutgers, New Jersey Medical School, and Senior Vice President for Neurosurgical Services at RWJBarnabas Health. Welcome to the show. Thank you, Dr. Gross, for being here. Can you tell us a little bit about your background information, who you are, where you come from, and what you do over at Robert Wood Johnson University Hospital and the Robert Wood Johnson Medical School?
Well, my pleasure, and thanks for having me. I'm a neurosurgeon. I'm a professor of neurosurgery and the chair of the Department of Neurosurgery here at Robert Wood Johnson Medical School, as well as New Jersey Medical School. I focus on functional neurosurgery, which is the treatment of people with disorders that affect function, such as movement disorders, what we're going to talk about today, as well as epilepsy, psychiatric disorders, and even a little bit of pain. I've been here for about a year and a half and spent most of my career down south in Atlanta, but I'm happy to be up here to help lead the programs up here.
Okay, so as you stated, you do a lot of movement disorders, which very few neurologists or neurosurgeons in New Jersey even know much about. So tell us the most common neurologic disorders that you have in the practice, describe each one, and just address a little bit about it.
Sure. Well, the most common one is essential tremor. So essential tremor is a disorder that affects people, especially as they get older. And as noted in it, it's tremor. Essential means we don't really know what causes it. And essential tremor has essentially its sole symptom being tremor. And this happens when you do things, when you have the intention to move or do actions. Can be refractory to medical treatment and can be very, very disabling for people carrying out their activities of daily living. The next down the list would be Parkinson's disease, which most people are familiar with to some extent. Parkinson's disease has tremor as part of it as well, but it also has other symptoms, including slowness of movement or bradykinesia, as well as rigidity, difficulty with limbs being stiff, and some gait problems. And that is about, that's less common than essential tremor. Essential tremor happens in about 2% of the population, Parkinson's disease in about 0.3% of the population. And there are other more rare disorders like dystonia, which leads to contractions and postures that can be very disabling. And even many people have heard about Tourette's syndrome, which is a movement disorder where someone has uncontrollable movements and even some vocal tics. Those are the major forms of movement disorders that we deal with, and there are a couple of others as well, like Huntington's disease.
So again, essential tremor is the most common one of all of them, which a lot of people coming as a internist, I see a lot of that in the office. And there's not very much that we can do other than tell the person, especially if they're having trouble writing checks, to put their elbow on the table to write the check. We do sometimes use the beta blockers to hopefully help, but we have had to go higher and higher, and it basically only helps a little bit. The person basically has to stop doing certain things if they're under stress, it seems to be much worse for them than if they're not under stress. If they haven't had a good night's sleep, they seem to have more of that also. And basically, a couple, the one who has it will probably pawn some of the stuff off on the other one, since they can't do a lot of the stuff that they used to be able to do. And then we get over to Parkinson's disease, which everyone hears about, but can you tell us really what the difference is between an essential benign tremor and Parkinson's disease and the common signs and symptoms of Parkinson's disease?
So it's interesting to hear you use the term benign tremor. I'm not, that is what it is called, but I certainly don't agree with that. It can be quite malignant in its effects on people's activities of daily living. As you noted, you can't write checks. It's very difficult to eat and drink. You can't eat soup, can't handle a hot cup of coffee, and can't button your clothing. And that's an interesting disorder because at rest, and this is one of the fundamental differences between the tremor in essential tremor and in Parkinson's disease, at rest in essential tremor, there's no tremor. And it's only when someone goes to do the things that define us as human beings. So it can be very, very disabling for people. The treatments are initially pharmacological, as you mentioned, one of them. Myceline is another drug that we use, but they can be very ineffective. And that leads people to consider surgical treatments, which we'll get around to in a bit. Parkinson's disease is quite different. The tremor that occurs in Parkinson's disease is at rest. So when you see someone in a waiting room and they're shaking, that's probably a Parkinson's disease tremor. The frequency of the tremor is a little bit slower, but it's the typical sort of rest or pill rolling tremor like that. But it can be in all four limbs as well. But in addition, there's a slowness to movement. So when you try to have them move their hand like this, they can't go like this, rapid hand movements. They're like slow like that. They can have difficulty standing up from a seating position. And of course, when they walk, you'll see decreased arm swing, stutter steps. They tend to freeze in tight places. And so it can be very disabling because especially when they're in a little bit more anxious circumstances, like going to the supermarket and getting up to the cash register and then freezing at the cash register and not being able to move. So it's a much more pervasive disorder in terms of life and quality of life. Now, that disorder at the outset can be treated medically and usually is well treated medically for a period of 3 to 5 years, where someone taking the right medications for Parkinson's disease can function essentially normally. But it is a progressive disorder. And as those dopaminergic neurons in the brain continue to die off, it gets more and more difficult to treat medically, to the point where we can't have good functioning all day long, and there's fluctuations from good to bad to good to bad. So those are the essential differences in those disorders.
So there are different stages then in Parkinson's disease, correct?
Correct. Parkinson's disease, actually, there's a stage that predates the presentation of any symptoms whatsoever. So it's by the time the symptoms show up, patients will have lost 50% of the neurons in their substantia nigra, a region of the brain. Up until that point, the brain can compensate such that there are no symptoms whatsoever, but then you get to a tipping point. The earliest symptoms will often be constipation, which is due to effects in the intestine, actually. That's actually where the first neuronal effects are, and or difficulty with smell, so anosmia, because that's another area that is close to the external part of the world that gets affected early on. So that's a sort of pre-stage where there's no symptoms, but the disease is present. And then it presents in the first stage, often with some tremor or some stiffness, and once a diagnosis is made, then it can be treated very easily medically. And that goes on for, as I mentioned, about 3 to 5 years. And then we get to this period after that where we get into what we would call advanced Parkinson's disease, where patients are having fluctuations in their motor function, from slowness of movement to the medications being arguably too effective, where there's advent of writhing movements. And if anyone has seen Michael J. Fox, for example, in recent years, you will see what that writhing movement is like. And it's also at that point that we begin to consider more aggressive therapies, including surgical therapies. And then there's the late stage of the disease, where progression has continued to the extent that there's other systems of the brain that are affected, like autonomic, with blood pressure changes, maybe some urinary problems, some thinking problems. There can be dementia in about a third of patients, and walking problems where there's a lot of falling. So those are the advanced stages of disease, and sleepiness, daytime sleepiness is a major one.
And how do you diagnose Parkinson's disease?
So for the most part, Parkinson's disease is diagnosed clinically by our neurologists, typically. Based on that, those symptoms that I mentioned, we use the acronym TRAP for tremor, rigidity, akinesia, slowness of movement, and postural instability and gait disturbance. So if you've got three of those symptoms, then we make the diagnosis clinically. It's also then confirmed by using the medicine Sinemet, which is the precursor for dopamine, which is the neurotransmitter that's mainly affected. And when you give L-Dopa, and it alleviates those symptoms, that pretty much nails the diagnosis. There can be times when we have some diagnostic uncertainty. It has been said that even the best neurologists in the world are wrong 25% of the time with their diagnosis. And so we have some nuclear imaging studies, like fluorodopa and DAT scans, that can help distinguish true Parkinson's disease when there's some diagnostic uncertainty.
So over the last 10 years, it sounds like technology has changed. What are the types of technologies that you're using today that you didn't have 10 years ago?
Some very good ones. Starting with essential tremor, we do have we do stand on the shoulders of giants, or there's nothing new under the sun. So many of the things we do, you can look back 50 years or even 100 years and see some precursors of these things. But the surgical treatment for essential tremor had for a number of years been what we call thalamotomy, where we go into the thalamus, which is below the cortex in the brain, and make a hole. That's what hotomy means. So it's a very small 8-millimeter hole called a thalamotomy. That's been being done since the 1950s, and then that was supplanted in the 1990s and 2000 noughts with deep brain stimulation. So deep brain stimulation all but eliminated thalamotomy because it was non-destructive. But it's been a great treatment for essential tremor, and as I'll mention, Parkinson's disease and other things. But it does require implantation of hardware and sort of the maintenance that goes along with that. And then in 2016, so within the last 10 years, we had the approval of Focused Ultrasound, which is a way of doing thalamotomy like we did previously, but instead of having to make a hole in the brain and the skull to introduce a probe, like you would for that or for deep brain stimulation, we can make a hole in the thalamus, a thalamotomy, non-invasively or without an incision. And so that's a procedure that can be done in just a couple of hours without ever cutting skin. And so that's been revolutionary. Interestingly enough, the idea and the proof of focused ultrasound for doing this dates back to the 1940s. It just hadn't been gotten to the point where we could technologically do it in sort of a turnkey way. And then that can be used in essential tremor and can be used in some forms of Parkinson's disease as well. In Parkinson's disease, we've had since the 2000s deep brain stimulation, which is a wonderful treatment. But again, there's implantation of hardware, and some of the things that are advancing, although not to the point yet of FDA approval, they're in clinical trials, are gene therapy and cell therapy, where we implant something that alters the gene function within the certain areas of the brain, or cells to supplant the cells that we're losing every day in Parkinson's disease. So gene and cell therapy are not yet FDA approved, but I expect that within the next 5 or even, I would say 10 or even 5 years, that we might have approval of some of these new techniques.
Now, the Focused Ultrasound Treatment Program, which is located at RWJU at University Hospital, Somerset, it's the only site in the health system that has it. How does this technology work?
So yeah, we are. It was a goal of mine in coming here to get that up and going. It was something I was doing when I was in my previous role down in Atlanta. It's a great tool. It works by heating up the brain like we would with the old style thalamotomy, which used an electrode. In this case, we heat up the brain using acoustic energy. So there's approximately 1,000 small transducers that look much like an ultrasound probe that you would see if you were having a test, if you're pregnant and you want to see your baby. So that's a diagnostic ultrasound. So there's 1,000 of these probes that focus their energy at one single spot, such that the rest of the brain only experiences a very trivial amount of heating. But where they come together, we can heat to the extent that we can burn a hole, much like taking a lens and focusing the sun's energy on a leaf to burn it. So that's done in the MRI scanner. Patient will come in the morning, change into their gown. One small detail is that we need to shave someone's head for this, so which is not trivial, especially if you wear your hair longer than I do. But we need to transduce that acoustic energy right into through the skin and through the bone. So that's a necessary part of it. The good news is that unless you look like me, your hair does grow back. Then you come into the MRI scanner. You're positioned in a frame that attaches to your head, and you lay there. And we, as on the practitioner side and the technician side, will do some MRI imaging, pick our target, and adjust using the computer that comes with the system those transducers to achieve that little envelope of heating deep in the thalamus. And we do that over a series of 3 or 4 steps while we're testing tremor in our patient. So we come in and we see how we're doing, and when the tremor goes from this to that, we know we're done. And that lasts about an hour and a half to 2 hours to do the procedure. Go home the same day. Many of our patients leave the hospital to go to the nearest restaurant and eat some soup for the first time in decades sometimes.
So why do some people get this focused ultrasound recommended while others do surgery?
It's to some degree a matter of preference. Deep brain stimulation for essential tremor has been around again for over 25 years, but it does involve implanting hardware. And especially for essential tremor, where there's one symptom that patients are managing, and they're not seeing a doctor regularly for it. They don't want to be tethered to having a brain stimulator, or they don't want to have an open incision made. It also has a slight but a real chance of infection or a bleeding complication. And none of these problems beset focused ultrasound. So for that reason, patients who are less inclined to have a surgical procedure or to have a permanently implanted device will choose focused ultrasound. Conversely, if you have any side effects from the focused ultrasound, they can be permanent, albeit uncommon. Whereas for DBS, those side effects are easily managed by adjusting the stimulator intensity. And the clinical results of focused ultrasound are great, but they're a little bit better for deep brain stimulation. So someone who is having maybe greater amount of tremor in terms of the amplitude may choose to have the implanted device over focused ultrasound. So some of it's patient choice. There's also the issue of bilateral procedures. When we do the focused ultrasound, we can do the other side. So one side of the brain treats the opposite hand, but usually the tremor is bilateral on both hands. With focused ultrasound, we can do the second side, but we have to wait 9 months to do it. Whereas with deep brain stimulation, we can do both sides at the same time. So someone that's more interested in an immediate result from both sides might choose the one versus the other. And then there are some details medically where we might be more inclined to one versus the other if someone is very advanced in years and does not want to have anesthesia. You know, we've done this procedure for people in their 80s or even in their 90s. So as someone has more medical problems or more risk from anesthesia, then we are certainly more inclined towards doing the focused ultrasound procedure where you're awake. It's not a bona fide surgical procedure per se, than deep brain stimulation. And then for Parkinson's disease, there's some other considerations which weigh in, such that for Parkinson's disease, we're much more likely to do deep brain stimulation than we are to do focused ultrasound, where it's the opposite now for essential tremor.
And who's the appropriate candidate for treatments?
If you have a positive diagnosis of essential tremor and it's not something else masquerading as that, and you have failed a trial of those two medications we've discussed, beta blockers and myceline, and you are, relatively healthy, you can undergo a procedure of some sort, you're a candidate for focused ultrasound. Again, if you have stable, manageable medical problems, you could be as well a candidate for deep brain stimulation. And that's for essential tremor. For Parkinson's disease, now, what's interesting about Parkinson's disease is that the tremor in Parkinson's disease sometimes is very difficult to treat, even if the other symptoms are well treated or not even advanced. So some patients with Parkinson's disease will be candidates for focused ultrasound or deep brain stimulation very early in their disorder. I'm not sharing anything that's not public knowledge, but Michael J. Fox had a thalamotomy very early in his years when it was just the tremor that was bothering him. And so focused ultrasound and deep brain stimulation may be used very early in Parkinson's disease, but more typically we wait until there are those motor fluctuations that are untreated or not completely treated by medicine in that 5-year range, 5 to 10-year range. And then someone would be a candidate for deep brain stimulation or even for one of those clinical trials of gene and cell therapy. There is a form of ultrasound that we can use for that stage called focused ultrasound pallidotomy, where we make a hole instead of the thalamus in a structure called the globus pallidus. And again, that's something we've been doing in an invasive way for many decades, but now we can do that with focused ultrasound as well for people in advanced stage Parkinson's disease with those symptoms that are beyond tremor.
And what are the side effects for the patients?
For the thalamotomy, the main side effects are when we affect areas that are around the area that we're aiming for. So we're aiming for what's called the motor nucleus in the thalamus. There's an area right behind it called the sensory nucleus. And if there's any encroachment on that, that can lead to some numbness and some tingling in the fingertips, perhaps, or in the mouth. Those are the typical areas that are right nearby. And that might occur immediately after the procedure, but is typically transient, and that can be persistent in about 10% of patients. We also can get some effect on gait or balance because we are in the pathways coming from the cerebellum of the brain into the thalamus that mediate that tremor, and the cerebellum is involved in balance. And again, we can have up to a quarter of patients have balance problems immediately after the procedure, but it's typically transient, and only about 4% of patients are left with any sort of a persistent problem with balance or gait. And then there's a small number of patients that can have some weakness in their arm because the pathways carrying the motor signals are right lateral to where we're going. And again, that can happen sometimes immediately after surgery, but it's only persistent in about 2% of people. So the adverse effects are overall up to 10%, but usually in a lower percentage of patients. That's from thalamotomy with the focused ultrasound. With deep brain stimulation, we get those same side effects, but they can be managed by turning the stimulator intensity down. However, tremor effects begin to come back, and most patients that experience any of those side effects actually choose to live with the side effects rather than live with the tremor. So people really like to have the tremor go away, and they're willing to put up with some mild adverse effects to get to that place.
How can patients learn more about this cutting-edge technology?
Well, you can go on your friendly internet and search RWJ and Focused Ultrasound, or just RWJ and ultrasound, and you'll pull up a couple of links. And within those links is information, as well as how to get in touch with me and my team to help you figure out if you're a candidate for this and how we can get you there.
As we're concluding the show for today, what key messages do you want to leave our audience about the neurologic services at RWJBarnabas Health?
Well, one of the reasons I came to this place is to help to advance the services that we offer for common disorders like spine, brain tumor, but to be able to offer the very best care that you can get anywhere. There's a lot of institutions and practitioners around in this region that provide excellent care. And yet for some of the more challenging conditions, like tremor, like Parkinson's disease, like epilepsy, brain tumors, and even some other disorders like depression, we aspire to be able to offer anything that's available at the best institutions across the country. And we're making great progress with that. So we provide excellent care from excellent clinicians. We are all up to date and helping to advance the latest research into these conditions. And there's nothing that we won't talk to you about, whether it's thalamotomy with focused ultrasound, using a laser to do procedures, using a gene therapy, potential clinical trials that we're involved in the tumor space or in the epilepsy space or what have you. So we believe that we provide the best advanced care that you probably can't get until you go somewhat north and somewhat south from us.
Thank you for bringing the best technology available to a small community and allowing patients to have the best care with, close to their own home.
It's my pleasure. Thanks for having me.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about RWJBarnabas Health's neurological services, please visit www.rwjbh.org/neuro, NEURO.